Hello everyone, myself Vivek Devani and my topic is Epidemiology and Management of Multiple Sclerosis. So first of all, what is multiple sclerosis? So multiple sclerosis is a progressive autoimmune disease characterized by selective demyelination and inflammation and gliosis. So it is a demyelinating disease of central nervous system which affects brain and spinal cord.
So firstly, the epidemiology of the multiple sclerosis. So the multiple sclerosis, it was first described by Dr. Jean Charcot in 1868, and he described it in terms of the three cardinal symptoms of multiple sclerosis, which is intentional tremor, scanning speech, and nystagmus, which is now known as the Charcot's neurological triad for the multiple sclerosis. So multiple sclerosis has approximately affected 4 lakhs people in United States, and worldwide around 2.1 million people are affected due to multiple sclerosis. The onset of the multiple sclerosis begins at the age of 20 to 50 years old, and it is uncommon in children. And we can say that the multiple sclerosis is generally affected, generally has shown the symptoms only in 3 to 5% of population before the age of 16 years. And the youngest one to acquire the symptoms of multiple sclerosis is of only 2 years old. And only 9% of the population has shown symptoms of multiple sclerosis after the age of 50 years. And it is more common in female than in male, with a ratio of 2:1 to 3:1. But when men acquire multiple sclerosis, there is a high chance of rapid progression in men than in female. And interestingly, when the symptoms of the multiple sclerosis start after the age of 50, the prevalence is same for men and women. And and we can also say that from last 5 decades, the prevalence and incidence of multiple sclerosis has been increased a lot. Multiple sclerosis has a predominantly affecting the white population more. So the African Americans are at a very less chance to acquire it. But once they acquire it, they will have a very rapid progression, and they will have a very frequent relapse. And also we can say that they will have the involvement of optic nerve or the spinal cord. There are very low rates for the Asians and the Native Americans to acquire it. So the epidemiological studies have divided into different geographical locations according to the multiple sclerosis prevalence. So in the higher frequency areas, which will be the temperature zones, they have kept the northern United States, northern Europe, southern Canada, New Zealand, and southern Australia. In medium frequency, they have kept southern United States, southern Europe, and rest of the Australia. And the lower frequency, they have kept Asia, Africa, and the Native America. So now, before going for the management, let's see the assessment for the multiple sclerosis, because without assessing the patient, we cannot plan the management for the patient. So in assessment, first there will be demographic data. So the positive, so all the components of the demographic data are mentioned over here. The positive findings in the demographic data, we will discuss only the positive findings. So the positive findings which we see in the demographic data are the age of the patient will be between 20 to 50 years of age, and the gender will be more female, because it affects more in female than male. And after the demographic data, we will see the socio-economic status, which we will take with the help of the modified Kupuswamy scale or Kupuswamy scale, the latest version. Next will be the chief complaints. The patient will have mainly the complaint of easily fatigue, and he may have difficulty in chewing food, swallowing food. Also, like he may have difficulty with like his weakness increases on activity, and as his days start, and with rest his weakness gets improves, and fatigue also improves with rest. He may also have a chief complaint of like when he flexes his neck in the forward, like bend his neck forward, he might feel a sharp shooting pain in the neck, which is known as the Lhermitte's sign positive, which is a classical sign seen in the multiple sclerosis. Next as we go ahead, we will come to history part. So in the history, all the components are mentioned over here, but generally the positive history will be the migration history, as multiple sclerosis is more common in the white population, in the Americans or the European countries. So the patient will surely have a migration history. If the patient has lived first 15 to 20 years of his life in any kind of European countries and then have migrated to any kind of Asian or the African country, he is having a high chance to develop multiple sclerosis. After that, there will be a positive family history of genetics, as it is a genetical condition and it's a risk factor for, as it is a risk factor also for it. So there is a high chance of having a positive family history. Next will be the environmental history. As environmental history, we can say that as the temperature of an area increase, there is a total chance of the patient's symptoms to get increased, which is known as the Euthop's phenomena, which suggests that as the temperature increase, the symptoms of the multiple sclerosis also have a hike. So next will be on observation. So the components of the on observation are mentioned over here, but the positive findings are the build of the patient will be ectomorphic due to age. The posture of the patient in anterior, lateral and posterior view will show some of the changes, such as rounded shoulder, hunchback, even forward head can be seen. Forward head posture can be seen, and spinal curvature abnormalities can be also seen. And the next is the gait. The gait can be altered due to increased tone of the muscles in the lower limb, or due to muscle weakness, or due to decreased range of motion. Even the gait may show a specific kind of attitude of limb. Next can be the mobility aids. There is a high chance that the patient is using some of the mobility device such as crutch, cane or walk. Next will be on palpation. So the contents of on palpation are mentioned over here. Generally in on palpation, we will not have any kind of abnormality. All the things will be absent or either normal. So the next will be on examination. For on examination, first will be the vitals. So in vitals, we are generally taking the heart rate, blood pressure, respiratory rate, temperature, and nowadays we are also taking the SpO2 of the patient. Next will be the higher mental functions. In the higher mental functions, first will be the consciousness of the patient, which we generally take using the GCS, but it is generally used when the patient is in admitted in the hospital or in the ICU or something. In the IPD patients, it is generally not needed. Next will be the orientation of the patient, the time, place and person. So in case of multiple sclerosis, person will be totally oriented, totally normal regarding time, place and person. Next will be the memory of the patient, the immediate recall, short term memory and long term memory. Generally the immediate recall and short term will be affected, long term will remain normal. Next will be attention. So due to cognitive impairment, there is a high chance of the attention of the patient getting affected. Next will be the cranial nerves. So the cranial nerves have a high chance to get affected, and usually there is a high chance of optic neuritis. So the optic nerve is highly affected in the case of multiple sclerosis, and there are also chance of many other nerves getting involved. Next will be the sensory examination. So for the sensory examination, the superficial sensation, deep sensation and the combined cortical sensations, there is a high chance for all of them to get affected, and superficial and deep sensations such as touch, pain, pressure, temperature, all may be somewhat diminished, and kinesthesia and proprioception will also get impaired. And for the combined cortical, we can say that the tactile discrimination and stereognosis will also be affected. Next will be the reflex examination. So for the reflex examination, so first of all the superficial reflexes. So the plantar reflex may be affected. We may see a Babinski sign positive over there. And in the deep tendon reflexes, we may see hyperreflexia due to the increased tone in the body. Next will be the pathological reflexes. In pathological reflex, we can say that we may see a Babinski sign positive or a clonus, ankle or a patellar clonus. Next will be the tone assessment. So the tone of the muscles of the anti-gravity muscles might be high. We will generally use the modified Ashworth scale to check the tone. Generally it assesses the spasticity, and there is a high chance of spasticity present of grade 1 plus or 2 in the anti-gravity muscles. Next will be the voluntary control. So for checking the voluntary control, we generally uses the Brunstrom grading system, and in which it says that if the grading is of 5 or 6 only, then only we can go for other findings of range of motion and MMT. If the person is having grade 5 or grade 6 for Brunstrom grades, then we will go for manual muscle testing or range of motion. Next will be the range of motion. So the passive range generally will be normal, but the active range generally will be reduced. Next will be the manual muscle testing. So there is a high chance of the proximal muscle to get affected, such as the hip flexors and the shoulder abductors. There is a high chance of having a grade of 3 plus or 4 according to the MRC grading for the manual muscle testing. And last will be the equilibrium test. So while equilibrium tests are generally for the balance and coordination, so we will have affection in it also, and we may have fair or poor grading according to its grading system. So next will be the functional scales. So the functional scales which we can take in the case of multiple sclerosis are the Berg balance scale, which is a gold standard scale for assessing the balance of the patient. Next is the functional independent measure. It is generally used to assess the independence of the individual doing in his all the daily living activities. Next can be the multiple sclerosis quality of life questionnaire is 29, which is generally used to assess the quality of life of the patient of the multiple sclerosis. Next can be the mini mental state examination, which can be used to assess the cognitive impairment of the patient with multiple sclerosis. And the last can be the multiple sclerosis impact scale, which can be used generally used for assessing the physical and psychological impact on the patient suffering from the multiple sclerosis. So the next is the problem list. So firstly, the patient have a complaint of easily fatigue. He is also having complaint of difficulty in chewing food, swallowing food, and also having slurred speech, and also the dropping of the upper eyelid. He is also saying that he is having problem regarding the symptoms. As the day progresses, his symptoms gets worsened, and as he rests at the night, his symptoms goes away. And he is also complaining of severe neck pain when he is trying to bend the neck forward. And also there is reduced range of motion, reduced strength of the muscles, and reduced sensations, altered gait pattern, and also there is a chance of altered bladder function. Next are the goals for the physiotherapist. So the first goal will be always to educate the patient regarding his or her condition. Next will be to reduce the pain for the patient. Next is reduce fatigue of the patient. Next will be reduce spasticity of the patient. Next is to improve the bladder control of the patient. Next will be to improve the balance and the coordination of the patient. Next will be to improve the cognitive functions of the patient. Next is to improve the speech and swallowing for the patient, and many more. So the next is the management of the multiple sclerosis. So for management, first is the management of pain. So the pain in multiple sclerosis has been described in 4 different categories. So first is pain is directly from the multiple sclerosis. Second is pain due to any kind of secondary symptom of the multiple sclerosis. Third is pain due to any kind of drug treatment ongoing in multiple sclerosis. And fourth is independent pain in multiple sclerosis. So generally the management of the pain is depend on the cause of pain. So in multiple sclerosis, there is high chance of muscular strain and joint malalignment due to prolonged chronic muscle weakness, which may lead to chronic pain. So for managing pain, we can give stretching maneuvers. Also the massage therapy can be used. Also for pain, we can use electrotherapeutic modalities such as ultrasound or TENS. We can also use hydrotherapy or the aquatic pool therapy, in which lukewarm water have showed a very effective result in the pain dysesthesia. Also for pain in the neck region due to Lhermitte's sign, we can give soft cervical collars, and also the pain due to faulty posture due to any kind of joint malalignment, we can prescribe any kind of other orthotic devices. Next is the exercise training. So the exercise training is much more safer in multiple sclerosis patient. We can start with strengthening exercise, aerobic exercise, even with the flexibility exercises. In strengthening exercise, we can go for progressive resisted exercises using the overload principle. For aerobic exercises, first we need to start with the static aerobic exercises such as static cycling and other all. And for flexibility exercise, we can start with the active range of motion exercises and stretching maneuvers. The exercise plan should be planned in such a way that the patient is taking exercise on the alternate days and on alternate basis, and the exercise should be generally planned in the early morning when the temperature of the body is generally at the lowest, and the fatigue is also generally not present early in the morning. Next is management of the bladder control. So in 50% or even we can say that more than 50% of cases there is a chance of bladder incontinence present. So for that we should have a particular schedule for avoiding, and we should instruct patient that not to consume caffeinated foods or meals after the evening, so to avoid the nocturia in the night. And we can also advise them and plan a particular cycle of voiding, and make them hurry to void as they have sensation of voiding the urine. So the next will be the management of fatigue. So while performing aerobic activities of moderate level, we should take frequent rest in between and then continue with the exercises. So we should always use the energy effectiveness strategies in which we will conserve the energy and reduce the task demand. In this way, the person may feel less fatigue and he may feel comfortable to continue with the exercises. And also the temperature should be cool enough. The clothing which is wearing while performing the exercises should be cool enough, and we should always keep the pre-planned intervals in between, so that the person if gets fatigue in between, we can make him sit and give him proper rest. And also we can say that we can also use these assistive devices such as powered wheelchairs, scooter or walkers. Next will be the management for sensory defects and skin care. So skin should be assessed on a daily basis, at least once in a day, and we should always keep the skin properly cleaned, use daily scrubbing or scrubbing techniques to properly clean the skin. And the sensory defects areas should also be cleaned on a daily basis. And we should tell the patient to wear the breathable clothes. The clothes should be not too loose, not too tight, or it should not have wrinkles on it. And the person should always have to change frequent positions to avoid the pressure source. If the patient is lying in supine, every 30 minutes to 1 hour, he or she should change his position. And if the person is in sitting position on a wheelchair or something, in every 15 to 30 minutes, the person should change his position to avoid the pressure source. In this way, we can have a proper skin care and manage the sensory defects. Next is the management of spasticity. So first of all, we can use the cryotherapy. We can use ice strokes in the manner of dermatome, so to reduce the spasticity. But we should always remember that some patients with sensory defects may have some unpleasant sensation regarding the icing due to the autonomic nervous system, the flight and fight response. So in that patient, we should always not use the cryotherapy. It is a total contraindication in that case. Next, we can use hydrotherapy along with PNF techniques. It is a much effective way to treat spasticity. Next, we can use passive stretching maneuvers to decrease the spasticity. We can also use the different kind of positioning, such as in anti-gravity position, such as in standing, kneeling, quadruped position, plantigrade position, or in standing. Next, we can also use the combination of physical therapy and the pharmacological therapy, in which we can give baclofen, which is a central muscle relaxant, to the patient. Next, we can also take care of the environment. If the environment is like too much stressy for the patient, if the temperature is too much, and if the patient is not much comfortable, there is a total chance that the tone of the muscle is going to increase. So all that things also should be kept in mind. And also we can use different techniques like such as tai chi, yoga, or aquatic pool therapy, in which the water temperature should be like 87 degrees Fahrenheit or 29.44 degree Celsius. It is really helpful in decreasing the spasticity. So the next will be the management for balance and coordination. So for that, always start with the balance control training, and always start with first training the static balance. So for that, use different postures such as anti-gravity postures, and progressively you can go for reducing the base of support, increasing the center of mass, and so on. And you can also use different kind of PNF techniques such as rhythmic stabilization for the static balance. In more progression, you can start with the dynamic balance training. So for that, you can use different techniques such as Swiss ball technique, and you can use vestibular wall training, and all that. And we can also use the different kind of equilibrium exercises, such as heel to shin exercises, standing with eyes closed, narrow base of support, walking in a straight line, walking backward, and all the others. And we can also go for the Frankel exercises to improve the coordination. So the next is orthos is an assistive device. So there is a high chance of foot drop present. So for that, we can give ankle foot orthosis or knee ankle foot orthosis, and also it is also of a not a static form, a dynamic form, in which we can add the functional electrical stimulation, so that the patient can use it to walk and continue the daily living activities, and it will also help to improve the muscle property. And also we can give different kind of assistive devices such as walker, cane, or crutches, in whichever the patient is able to ambulate. Next will be the management of speech and swallowing. So the speech and swallowing, first of all, for the swallowing, so the patient should be in a normal comfortable posture, in an erect posture while sitting, and the patient should keep a forward chin, and to try to swallow to decrease the risk of aspiration. And we can use the different techniques such as effortful swallow, and many more. And we should tell the patient to strengthen the muscle for the swallowing. We can use cold icy stimuli technique for the pharyngeal muscles to stimulate the swallowing, so the person can easily swallow. And for the speech, we can try to strengthen the muscles so the person have a proper speech. And for cognitive training, our role is for referring the patient to the neuropsychologist, so that the neuropsychologist can start with the cognitive behavioral therapy, so the patient's cognition come to normal.
My reference is Physical Rehabilitation by Susan O'Sullivan, 7th edition. Thank you all for listening me.